Yeah, good afternoon, everybody who's now online. Dirk, thank you very much for the kind introduction and the invitation to the C-Star lecture. Just to give you a quick impression from where I'm to you. So Leipzig is located in middle Germany, close to Dresden and Berlin. And I'm working, as Dirk said, at the university hospital and in a close collaboration with the Max Planck Institute of Cognitive and Human Brain Science, which is just in 5 minutes walking distance to the hospital. And here you can see my 3 postdocs who did most of the recent work. And here you can see me in my office where I'm now speaking to you about. So first, some issues on the functional neuroanatomy of language networks. Second, how lesions impact on these networks. Third, how we modulate language networks with TMS in terms of a virtual lesion approach. And finally, I will show you how we map disruption and reorganization of language networks in stroke patients with aphasia using functional MRI. So let's start with some historical considerations. So one of the first networks for language was postulated by Wrede K, who proposed that a posterior temporal language center is essential for analyzing sound images of words, while a second center located in the frontal cortex is essential for analyzing motor images of words. So the particular appeal of this model, however, was that he assumed that the temporal and the frontal areas were mutually interconnected by a direct pathway, which he termed the fibre proprie. So Ludwig Lichtheim extended his model by adding a third center, a center of concepts. He called this the Begriffszentrum.
This conference will now be recorded.
And an indirect route via the concept centers. So unfortunately, this idea of 2 processing streams for language got lost, and for a long time, the model of Geschwin with a single pathway connecting Wernicke's and Broca's area dominated our view on the organization of language in the brain. So one aim of my research is to describe functionally and anatomically characterized networks for language using multimodal neuroimaging to better understand which pathways enable large-scale interaction within these networks. So in this neuroimaging study, we combined functional MRI and diffusion tensor-based tractography to identify networks observing auditory comprehension and repetition. We found that during repetition of pseudowords, a network of superior temporal and posterior frontal nodes were activated. So in contrast, comprehension of intelligible speech activated nodes in the middle temporal lobe and the anterior frontal cortex. So partly overlapping temporal-frontal networks were activated during repetition and comprehension. Our question now was which anatomical pathways connect these nodes during repetition and comprehension. And using probabilistic point-to-point tractography, we found that the network for comprehension, all interactions between the temporal and frontal nodes were mediated through this ventral pathway, which is running between the insular cortex and the putamen to the prefrontal cortex, and which is the extreme capsule. And together with the middle longitudinal fascicle, the extreme capsule is the ventral pathway for language. And we think that this extreme capsule nicely corresponds to the aforementioned fibre proprie in Wernicke's model. So during repetition of pseudowords, nodes in the superior temporal and posterior frontal cortex were connected via a dorsal pathway, which runs through the deep white matter of the parietal lobe and which is the well-known superior longitudinal and arcuate fascicle. That is, these two dorsal fascicles form the dorsal pathway for language. So in sum, our results indicate that at least two major association tracts observe auditory language processing. The arcuate and superior longitudinal fascicles provide connectivity between the temporal lobe and the premotor cortex and enable repetition, while the extreme capsule together with the middle longitudinal fascicle connect the temporal lobe with the prefrontal cortex and enable comprehension. So similar architectures could also be described in the left hemisphere, for instance, for syntax, and in the right hemisphere for prosody by my colleagues from the Max Planck Institute. So in more detail, synthesizing the results of more than 2 decades of neuroimaging, I would like to suggest the following model on auditory language processing. First, auditory language input is analyzed in primary auditory areas. So, and phonological analysis then occurs more ventrally along the superior temporal sulcus, and lexical and semantic analysis occurs even more ventrally in the middle temporal gyrus, the angular gyrus, and the interior part of the inferior frontal gyrus. And exchange between these areas is provided by the middle longitudinal fascicle and the extreme capsule, constituting the ventral stream, which is essential for comprehension. On the other hand, information flow to the inferior parietal cortex allows for sensory motor integration and interaction with the posterior frontal cortex via the arcuate and superior longitudinal fascicles, and implements repetition within the dorsal stream. In addition, naming requires a tight interaction between the prefrontal cortex and the temporal lobe via mainly the extreme capsule. So to illustrate how well this model explains aphasic deficits in patients, I will show you 2 case examples. So the videos are in German, but I think the translations will help you to recognize the aphasic disorder. So the first patient was a 49-year-old pharmacist who presented with a sudden onset of an isolated aphasia caused by a dissection of the left internal carotid artery. So let's listen to him 2 days after the stroke.
Mir am Mittwoch aufgetroffen, um 2 Uhr morgens. Ja, meine Freundin hat dann gedacht, ich sollte dann doch mal zum Burschen gehen. Ja, die hatten mir da komische, ich weiß nicht, was sie gemacht haben. Die haben mich verschiedene Fragen. Sie hatten mich verschiedene Antworten. Ich kann es nicht sagen. Haben sie mich irgendwann mal dann hier eingespannt. Ne, haben sie mich hier ja, das ist
Stern?
Strom.
Stern?
Stern.
Spruch?
Bruch. Ne, Spruch.
Lotterie?
Lotier, Litor, lotiert, Litor, Litor. Tablett, ne.
Ich sitze an einem
Tisch.
Gut.
Tisch. Ja, Buch. Kartoffel, nein,
Ich packe den
Kartoffel, nein, sowas ähnliches.
Den Kopf.
Kartoffel. Kaffee.
So we had a fluent aphasia with very frequent phonematic but also semantic paraphasias in his spontaneous speech, but also in repetition and naming. And I didn't show you this, but language comprehension was also disturbed. So his aphasia was caused by this strategic lesion of the posterior superior temporal cortex, including Wernicke's area. And from the network perspective, the lesion affected both streams, resulting in deficits in repetition and comprehension. So the second patient is a 69-year-old engineer, and he was also admitted with a sudden onset of an isolated aphasia. So let's listen to him 3 days post-stroke.
Haben Sie was mit Menschen zu tun in Ihrem Beruf?
No.
Ja, okay. Ist es ein Handwerk? Nicht so richtig? Nein, okay. Sind Sie hier in Leipzig beruflich tätig und arbeiten auch noch? Nein, arbeiten nicht mehr. Okay. Stern. Ja, gut, prima, super. Lotterie.
Lotterie.
Ja, sehr gut, prima. Gut. Was ist das? Wie nimmst du es nochmal? Okay. Wie nimmst du es nochmal? Sehr gut, prima.
So here we heard mainly my postdoc speaking, Annika, because the patient presented with a severe, unfluent aphasia with a very high effort of speech, and repetition and naming was only possible with production of some syllables and with frequent phonetic errors. In addition, and clinically even more relevant, he presented with a severe motor speech disorder with dysarthria and apraxia of speech. So his deficit was caused by this frontal lesion, which explains his unfluent aphasia and motor speech difficulties, while comprehension was relatively well preserved. So my colleagues from the Max Planck Institute investigated the relationship of brain damage and aphasic syndromes as diagnosed with the Aachen aphasia test. They showed that if Broca's aphasia was diagnosed with the Aachen aphasia test, frontal regions are affected by the stroke, while in Wernicke's aphasia, temporal and parietal parts were damaged. So this distribution is best explained by the vascular architecture of the middle cerebral artery and its major frontal and temporal branches. Thus, Broca's and Wernicke's aphasia represent vascular syndromes that are composed by the distributed processes, typically affected when the frontal or temporal branches are occluded. So we were interested in how acute stroke lesions affect the ventral and dorsal processing streams. To this end, we performed a Voxel-based symptom lesion mapping in 100 patients with acute aphasia. So lesion overlap covered the complete territory of the left middle cerebral artery, with the typical maximal lesion overlap located subcortically in the vascular territory of the lenticular striatal arteries. So using non-parametric lesion mapping, we found that repetition deficits mainly correlated with damage to the posterior temporo-parietal cortex, while comprehension deficits correlated with damage to anterior temporal and frontal regions. However, in both lesion maps, lesion maximum was located subcortically. So for repetition in the deep white matter of the temporo-parietal cortex in projection to the dorsal arcuate fascicle and superior longitudinal fascicle fibers, and for comprehension in the white matter between the insular cortex and the putamen corresponding to the extreme capsular fibers. So the study provides direct lesion evidence for the functional relevance of both processing streams. And indeed, we found a robust correlation of individual dorsal tract damage and repetition impairments and individual ventral tract damage and comprehension impairments. So this points to the importance of structural disconnection as an important mechanism causing acute aphasia. In another lesion study, we were interested in the phenomenon of aphasia after thalamic lesions, which is still a little bit a conundrum. And in the clinical evaluation of about 100 patients with thalamic lesions showed that about 20% of these patients presented with some kind of language problems. So, and lesions in these patients were mainly located in the medial part of the left thalamus and could nicely be separated from motor, here indicated in red, and sensation. In a second step, we performed a so-called Voxel-based lesion symptom network mapping that is based on resting state fMRI of healthy subjects. We calculated from each thalamic infarct lesion connectivity to all parts of the brain, and then compared this lesion connectivity between patients with and without language deficits. So we found that lesions in patients with language difficulties after a thalamic lesion have stronger functional connectivity to cortical regions that could be related to language processing. That is here the inferior temporal gyrus, the left dorsolateral prefrontal cortex, and the left angular gyrus. So we interpreted this in the way that language deficits after thalamic lesions are caused by dysfunction of the thalamocortical loops rather than by dysfunction within the thalamus itself. So in the next part of my talk, I will talk about modulation of language networks with TMS. So the studies I'm talking about were conducted by Gesa Hartwigsen in close collaboration with the Max Planck Institute. So in these studies, we investigated short-term plasticity into very simplified networks for phonological and semantic processing. So activation in the phonological network was evoked while healthy subjects had to decide whether an auditorily presented object, e.g. computer or Katze or tunnel, has 2 or 3 syllables. And in contrast, activation in the semantic network was evoked while they had to decide whether it's natural or man-made. First, so inhibitory TMS, it was a continuous theta burst stimulation protocol, was applied either to the phonological supramarginal gyrus or the semantic angular gyrus in order to induce a virtual lesion. And after inhibition, that is offline, subjects perform the 2 fMRI tasks in the scanner in order to map the mechanisms of short-term plasticity. So for both networks, we found a strong network suppression effect, that is, reduced activation beyond the inhibited areas remote from the stimulation site. That is, in the semantic network, reduced activation in the angular gyrus and in the anterior part of the IFG. And after stimulation of the supramarginal state or inhibition of the supramarginal gyrus, inhibition also of the posterior IFG. Behaviorally, a significant increase in the reaction times was only found for the phonological task, but not for the semantic task, here indicated with the black bars. To better understand the neural mechanism that allow the semantic network to keep a normal task performance, we performed different network analysis. This is what I showed you in the previous slide. that is, inhibition of the angular gyrus resulted in reduced activation of the stimulation site, but also in other parts of the network, in particular in the anterior IFG. In addition, using dynamic causal modeling, we were able to demonstrate that the model that best explained our data was a model in which the angular gyrus exerts a negative influence on the anterior IFG after TMS stimulation. So on a functional level, the stronger the inhibition of the angular gyrus to the anterior IFG, the longer the reaction times for the semantic decision. So far, these are the mechanisms of TMS-induced network disturbance. But what were the mechanisms of short-term compensation to keep the reaction times for semantic decisions normal? So we indeed found an increase of activation in the neighboring phonological network, here indicated in red. And of interest, the stronger the suppression effect of the angular gyrus, the stronger the increase of activation in the supramarginal gyrus. And the stronger this compensatory increase in the supramarginal gyrus, the longer the reaction times in the semantic task. In sum, using virtual lesion approach in healthy subjects, we were able to demonstrate that a neighboring network compensates for dysfunction in the lesion network. So from a more general perspective, the results of this and other studies using non-invasive brain stimulation suggest that at least two general mechanisms of flexible redistribution in cognitive networks. So we have within compensation, and that includes a stronger contribution of the remaining regions that initially contributed to the task, here indicated with the red arrows, and upregulation of contralateral homologue regions. In contrast, across network compensation may include recruitment of neighboring region of an alternative domain-specific network, or even recruitment of domain general networks, here indicated with black dots. So in this recent study, we transferred our approach to chronic stroke patients in order to induce short-term plasticity in the lesion language network. So here we included 12 aphasic patients who all recovered quite well and who presented only with mild to residual aphasia at least 6 months post-stroke. So in 3 examinations, patients either received inhibitory continuous theta burst stimulation over the anterior or posterior IFG, or they received placebo stimulation. After stimulation, patients performed the same fMRI decision task as we used in the healthy subjects. So here you can see fMRI activation in the sham condition, that is without TMS inhibition. In both tasks, patients showed a strong bilateral frontal activation. So after inhibition of the frontal target regions, we observed a strong network suppression in both networks, as we knew it already from our study in healthy subjects. So this suppression resulted in a significant increase in the reaction times for both the semantic and the phonological decisions. So the only compensatory effect we observed was an individual increase of lesion homologue activation in the right supramarginal gyrus, which correlated with individual increase in reaction times in the phonological decisions. That is, here we observed short-term plasticity with lesion homologue activation increase. We can call it within network reorganization in the phonological network in chronic stroke patients, but not in the semantic network. So let's come back to our patients. These two videos should give you an impression how well both patients recover. So the first patient after 3 months.
Bin ich hingefallen oder umgefallen und bin dann aber relativ schnell wieder aufgewacht. Also nicht aufgewacht, sondern ich bin nicht richtig hingefallen, sondern noch schwach geworden. Lotterie.
Unverhältnismäßigkeit.
Unverhältnismäßig. Ne, bla. Auf dem Tisch ist nichts. Buch, Koffer.
So, and the second patient after about 8 months.
Was sind Sie denn für ein Beruf?
Rentner.
Was waren Sie vorher?
Ich habe studiert Mathematik und habe den Elektriker vorher gelernt. Einen Tisch, ein Buch,
Stern. Lotterie.
So I hope I could convince you that both patients showed a pretty good recovery. And in the following, I will show you which are the neural mechanisms that enable such a favorable language recovery. To capture the dynamics of network reorganization, we set up a longitudinal study design in which patients were examined 3 times as early as possible in the first days post-stroke, in the subacute phase, about in the 2nd week post-stroke, and in the early chronic phase, about 6 to 12 months post-stroke. So at each time point, they were tested with an aphasia test battery from which we calculated a language recovery score. And in parallel, patients were examined with functional MRI using a very simple auditory comprehension task. And the target contrast here was the comparison of intelligible speech with unintelligible reverse speech, which then define our language effect. Just give you an impression.
Der Bauer bestellt das Feld. Zunächst nicht nutzen.
So, and patients were simply asked to press a button at the end of these stimuli. In our first study, we investigated this group of 14 acute aphasic stroke patients with distributed lesions affecting all parts of the left middle cerebral artery territory. And as a group, they showed quite good recovery over time. So fMRI revealed this overall pattern of language reorganization in the acute phase. Early, about 2 days after the stroke, we found little activation in the left inferior frontal gyrus. In the subacute phase, so about in the 2nd week post-stroke, we observed a strong upregulation in the entire language system with highest activation now in the right hemisphere in Broca's homologue. And in the chronic phase, months after the stroke, activation normalized, particularly in the right frontal cortex. So these changes of activation pattern led us to formulate an overall model of language reorganization in 3 phases. So with an acute phase of network breakdown, a subacute phase of network upregulation, and a chronic phase with a network activation normalization. So from these results, new questions arise. So, for example, what are the mechanisms of early network breakdown and recovery? can we predict language recovery from early fMRI activation? And particularly, what is the impact of lesion location on reorganization? So, and this latter question was not able to be answered from this cohort because lesions were distributed across almost the complete left hemisphere. So with respect to the mechanisms of early network disruption, we investigated a larger data set of patients with acute aphasia who were all investigated longitudinally with functional MRI. And our hypothesis was that diaschesis is the driving mechanism for this early network disruption. So diaschesis is defined as a dysfunction of areas remote to the lesion, but which are functionally connected to the lesion. And thereby, diaschesis could nicely explain our early network breakdown in the acute phase. So when we operationalized diaschesis as follows. First, we defined each patient's individual stroke lesion. Second, as in the thalamus study, we computed functional connectivity from the lesion to all other brain regions using functional resting state connectivity from a large sample of healthy subjects, and the resulting maps then represent the lesion connectivity for each single lesion. And third, based on this lesion connectivity, we defined regions of interest with high and low connectivity to the lesion and hypothesized that language activation in the acute phase is mainly affected in areas functionally highly connected to the lesion. And finally, from these compartments or regions of interest, we extracted our language effect in the acute, subacute, and chronic stage. And indeed, we found a selective increase of activation only for the speech condition in the compartment with high compared to low connectivity from the acute to the subacute phase. So this interaction of time, activation, and lesion connectivity was significant, and connectivity-dependent language activation correlated with language performance in the subacute phase. So in sum, this data suggests that resolution of diaschesis is a major mechanism of early language recovery, and in turn, diaschesis of early language disturbance. So the second question was whether early language activation may predict language recovery in the chronic stage. To this end, we analyzed early fMRI data and chronic outcome data in a supervised learning approach using a support vector machine. And we found that language fMRI of the subacute stage yielded correct outcome prediction in reasonable 76% of the cases. And this prediction was even more better if we added age and the level of early language performance. So in contrast, if we use only lesion location or language activation of the acute phase, prediction accuracy was just above chance level. So this means that language activation of the subacute phase contains outcome relevant information that predicts language recovery in the chronic phase. And finally, we were interested in the impact of lesion location on the mechanisms of language reorganization. So in this second study on the dynamics of language reorganization, this directly builds upon our previous study in 2006. And again, we investigated patients longitudinally from the acute to the subacute to the chronic stage. So here we recruited 34 patients with strictly frontal or temporo-parietal lesions. So both groups recovered quite well, with a significant better recovery in the subacute phase of patients with temporal lesions. So based on these clearly defined subgroups, we were able to define lesion-dependent candidate regions that support language recovery. First, preserved language regions in the left hemisphere, that is mainly frontal regions in patients with temporal infarcts and temporal regions in patients with frontal infarcts. Second, perilesional cortex, here indicated in yellow, close to the infarct. Third, lesion homolog cortex. And finally, also supramodal or domain general bifrontal control networks, here shown in blue. So here you can see language activation in the three phases rendered separately for patients with temporoparietal and frontal lesions. So our main findings were the following. So the strong dynamics within bifrontal regions with early reduced activation and subacute increase of activation were mainly observed in patients with temporoparietal lesions. In contrast, right frontal activation in patients with frontal lesions was present from early on and stayed almost stable across time. So independent of lesion location, we observed a continuous increase of activation in left temporal regions over time in both patient groups. In contrast, right temporal regions in the right hemisphere showed a significant stronger activation in patients with frontal compared to temporal lesions, independent of the time post-stroke. For a more precise investigation of the contribution of perilesional and lesion homolog activation to language recovery, we defined individual compartments. So the perilesional compartment consisted of a rim of 3 to 15 millimeters around the lesion. Within both the perilesional frontal and the perilesional temporal compartment, we found a continuous increase of activation from the acute to the chronic stage, which correlated with language performance in the subacute phase. So the homolog compartment consisted of the mirrored lesions. So significant lesion homolog activation was only found in the right frontal cortex, but not in the right posterior temporal cortex. To better understand which lesions evoke right hemisphere activation, we performed I will call it Voxel-based lesion fMRI activation study on a larger data set of patients who were investigated longitudinal with fMRI. That is, instead of the behavioral score, we used right hemisphere language activation as the dependent variable. And here you can see activation peaks in the right hemisphere in the different phases from which we extracted the language activation. So overall, our effects were weak, but I think plausible. So, for example, the strongest effect was that activation in the right inferior frontal gyrus was mainly associated with left frontal lesions. This is in line with lesion homologue activation only in patients with frontal lesions, as I showed you before. So all other effects, unfortunately, were even weaker. That is the association of right anterior temporal activation in the subacute phase was associated with lesion in the posterior temporal and parietal cortex, and right frontal activation in the chronic phase was associated with posterior temporal lesions. So together weak, but I think plausible relationships between fMRI activation and lesion location in the left hemisphere. So to summarize these lesion-dependent mechanisms of language reorganization. So first I showed you early network disturbance and recovery with reactivation of bifrontal control networks are mainly observed in patients with temporal lesions. Second, continuous activation increase of preserved left language areas and perilesional cortex is independent of lesion location and could be found in both groups. And third, lesion homologue activation is only observed in frontal lesions, but not in patients with temporal lesions. For neurorehabilitation, this could mean that areas most efficient to stimulate with non-invasive brain stimulation include, in particular, domain general frontal networks, which are typically preserved in middle cerebral artery stroke, but also preserved areas in the left hemisphere and perilesional cortex. So in particular, preserved areas of the network with high functional connectivity to the lesion as determined, for example, with resting state fMRI, connectome data could be a really appropriate target on an individual level. So on the other hand, our data provide no evidence, I think, for inhibition of right hemisphere regions in terms of a suppression of maladaptive plasticity. So together, I think such individualized brain stimulation has a high potential to increase adjuvant therapy effects. So to summarize my talk, I taught you that language networks are organized in ventral and dorsal processing streams. Anatomical disconnection and functional diathesis are important mechanisms of early network breakdown. Thalamic aphasia is mainly caused by a disruption of thalamocortical loops rather than the damage to the thalamus itself. Virtual lesions induced by TMS induce compensation within and across language networks. And language recovery after stroke can be described in 3 phases, with an early network breakdown, a subacute upregulation, and a chronic normalization of activation. Key mechanisms of network reorganization include perilesional reorganization, recovery of spared regions in the left hemisphere, and recruitment of domain general network. So, and language activation in the subacute phase contains outcome relevant information which predicts recovery in the chronic phase. So I'm finished now and open for questions.
Thank you so much, Dorothee. That was a wonderful talk. Again, as I said last week, also, you should be hearing applause globally now, but of course you can't hear the audience, but everybody is clapping in their homes, right? So, okay. So the first question is from Kirana Tsapkini. Thank you very much for a thought-provoking talk. How can we be sure that for repetition, it is the arcuate fasciculus that is involved and not the superior longitudinal fasciculus 3 connecting Brodmann's area 44 to supra-marginal gyrus?
Yeah, I think good question. I think it's difficult to differentiate between the two tracts, and therefore I always talked about these two pathways so as a common dorsal pathway, the arcuate fascicle and the superior longitudinal fascicle. That's correct, yeah. So probably it's the superior longitudinal fascicle, but I think it's, yeah, is it so important? It's just anatomical attribution.
Okay.
Yeah.
Then, and the second question by Kirana Tsapkini, what do you mean as compensatory role of neighboring networks? Does behavior recover, or is it adaptive compensation or maladaptive?
So we think this is really adaptive. So it's one possible mechanism of compensation, so that you have at least partly sparse network that can overtake function and help to restore the function. So probably it's a little bit theoretical, because it's difficult to show it really in lesion studies in patients, but in our TMS studies, where we are able to disturb very focally, we think we could observe this this mechanism. So we think it's compensatory, yeah, the neighboring networks. It's not maladaptive.
Then we have a question by Ev F, and I'm going to take a guess, and that is Evelina Fedorenko. If there is a non-language task control, is there a non-language task control to show that this pattern of activation normalization is selective to the language network?
Is there a non-language task to show that this, which pattern?
I can clarify. Can you hear me?
Yeah.
Yeah, I can hear you.
Sorry, yeah, this might be easier. I was just referring to the earlier studies where you show a ramp up of activity from the acute to subacute to chronic stages. Yeah. And I was just wondering if that's something that happens across the board, across diverse kinds of tasks, or is that something that's specific to the impaired network?
Yeah, you are completely right. So, yeah, so we are not able to distinguish whether our activation changes are language specific or rather domain general, because we only have one task, yeah, right. And we don't have different tasks because it's impossible to perform such a study. It's just attribution, so we interpret the activation in this or in the other way, yeah.
Okay, thank you.
Okay, and that goes for all the other question askers as well. If you want to clarify them, please go ahead and activate your mic, but please don't all do it all together. I had a few questions, but I'm first going to go to questions by others, since I'm hosting this. Lorraine Obler asks, can you tell us more specifically what the role of age was in recovery in the study seen on slides 30 or 31? So
30 or 31. So which was it? So age of the patients, or what's the question?
I think the role of age of the patients. How did that affect recovery patterns?
Yeah, so to be honest, we didn't include this as a covariate, and so our typical patients were between 50 and 70. So not as young and not really old. So, but you can read it in the methods. So it was a typical age distribution, and we not really investigated the effect of age. Yeah.
As I recall, you said that only when you added in age as a factor into your model did you see a significant effect. So I was wondering whether higher age was associated with better or worse recovery. I assume worse, but you didn't say.
Yeah. I think it's an important it's an important factor, and also in our prediction study, when we included age, we were better able to predict correctly the amount of recovery. Yeah, you're completely right, but we didn't include it as factor, so we didn't look onto this fact. Yeah,
you were better able to predict it such that older adults had less good recovery than younger adults. By younger, I'm assuming we mean people in their 40s and 50s.
So to be honest, I show you now this slide here. This is not explained by a support vector machine. So support vector machines just classify, but they're not really telling you upon which information the machine is classifying your data. So, but the classification was better when we added age to our model. But I can't tell you about the direction. So I would suggest it was the younger the better. But this is not so not the appropriate analysis to find out this.
Okay, we have a question by William Machen. This is amazing work. Can you tell us how awareness of deficit might relate to right hemisphere activations? For example, a simple hypothesis is that language activation outside the norm might be directly related to how much the patient notices problems in speech output and attempts to inhibit or correct this, relying therefore on right frontal inhibitory systems.
So we didn't assess deficit awareness, but I think it's a very interesting topic, and we have another research project on this. So what is the role of deficit awareness in aphasia? But yeah, it's thank you for this point, but I have no information to clarify this.
Okay, we have a question by Swathi Kiran. Thank you, Dorothee. What are your thoughts explaining the right temporal activation in frontal lesions, but not left temporal lesions?
Yeah. Hi, Swathi.
This is slide 32, I think.
Yeah, applying the right temporal activation in frontal.
And I see that someone, Joanna, is sharing their website, so please don't.
Yeah, the more important point is that we don't have right temporal activation and left temporal lesion. So not at all any lesion homolog right temporal activation. So, and even if we lower the threshold, there was nothing. Yeah, maybe this is an effect of our paradigm, but I think it's not so easy for the temporal cortex to just substitute function by the lesion homolog right temporal cortex. This is much easier for the frontal lobe, which is operating much more supramodal. But I think to substitute left temporal region, a Wernicke's region, is not easy possible. Yeah, it's very specific, this function we have there, and we didn't observe this substitution by right posterior temporal activation. The only moment in my talk where we observed this right posterior temporal activation was in GESA study, in the patient TMS study, where we have disruption of the left temporal parietal cortex by the stroke lesion and disruption of the left frontal cortex by the TMS lesion. And in this moment, we observed one time individual right temporo-parietal activation, which correlated with the behavioral performance. Yeah, and why? Yeah, so the other way around, so why we observe this in right frontal, in patients with left frontal regions, I think this is a completely different situation. If you have a left temporal, an intact left temporal cortex, then so the probably in interaction with this preserved left temporal cortex, there might be some activation also in the homologue. Yeah.
Yeah, no,
I'm not sure whether it's really functionally relevant. But I think without a functioning left temporal cortex, the right temporal cortex is lost.
I was just going to say that.
Sorry?
I was just going to say that because I think, as you say, there's a difference between right frontal homologue activation and right temporal, and there's some, you said there's no gradient, but there may be some level of gradient where without, you know, the right temporal activation is not the same level of efficiency as you would see in the right frontal. But that's and the study by GESA probably confirms that also in the TMS. But anyway, it is an interesting finding and probably worth looking at further.
Yeah. So the question now is, if we disturb this right temporal activation in these patients, whether they perform worse. Yeah, so this would be the final proof of the functional relevance. Yeah. This study has to be done.
So we have another question that I think is related to this one. Joanna asks, thanks for a wonderful talk. How would you interpret that only frontal lesions are showing the contralateral plasticity? I think that's
we talked about this.
Yeah.
Is it answered? It's not good answered, but we tried it.
And otherwise, Joanna can chime in. Question by Cindy Thompson. Thank you, Dorothee. I have several questions. One pertains to your conclusion that language comprehension does not engage the dorsal language tract. Friederici's and other models point to dorsal tracts, particularly for syntactic comprehension. Second question. In your perilesional studies, have you considered regions of hypoperfusion tissue within that region? And number 3. Do you think that right hemisphere upregulation might differ based on language domain?
Okay, hi Cindy. Hello. So the first thing is, of course, Angela is right if she says so. The dorsal pathways is involved in syntactic processing, of course. So she always has much more complicated paradigms, and I completely agree that there's no complete segregation between the streams. It's much more interaction between both streams. So this was simplified in my model, just also to being able to transfer it to the patient studies. So, and the second was, I lost it.
I can read it again. I have to find it too. Yes, in the perilesional studies, have you considered regions of hypoperfusion tissue? So
we didn't measure perfusion. We didn't perform perfusion measurements. So no.
Okay, and then number 3. Do you think that right hemisphere upregulation might differ based on the language domain?
So I think of course, yeah. This is so we had a simple language comprehension paradigm, and I think patterns would be very different if we will perform a production task, for example, or tasks which more involve syntactic processing, of course. Yeah. So this is, of course, one of the really of the limitations, that we only have this simple comprehension paradigm, but to my experience, this is the only task you can perform in patients who are really severe affected in the acute stage. Yeah. We tried it with production tasks and failed.
Okay, we have a question from Peter Turkeltaub. Thanks for a great summary of a very important body of work. You nicely demonstrated that different language processes rely on different parts of the left hemisphere language network. So, is there a concern that the longitudinal findings only apply to comprehension and not other language processes, since the fMRI task was sentence comprehension? So that ties in with your previous answer, I think.
Yeah, but yeah, I completely agree. This may also be one explanation why we all over observe much more dynamics in the patients with the temporo-parietal lesions, because probably the tasks were more sensitive to this patient group and didn't observe these dynamics as strong in the patients with the frontal lesions. Yeah.
So we do have a follow-up from Peter. We do have a follow-up from Peter. He says, I think the lack of right posterior temporal activity after left temporal lesions generalizes across tasks. We found the same thing in a naming task in chronic patients. That is, no right posterior temporal activity in people with left posterior temporal lesions. And the reference is to a paper by Skipper, Kaller, brain mapping.
And also, Peter, in your meta-analysis, there was much more right frontal activation across many different tasks compared to right.
Hi, it's Peter. Thanks for a great talk. So yeah, I agree, and we also found that relationship in that meta-analysis between the left frontal location and right frontal activity. Just one more word about the right temporal activity. We did find in that paper a correlation, at least, between the degree of right temporal activity and the naming outcome that was independent of lesion size and location. It's still just a correlation, so the TMS inhibition of that area would be a great study to follow up.
Yeah, I agree.
Okay, we have a question from Gerald Imazue. Thank you for your presentation. Are specific thalamocortical loops associated with specific aphasia syndromes?
So I can't answer this question. So it was a first try to show that it's more the connectivity of specific thalamic nuclei to the cortical regions than the lesion in the thalamus itself. And we have so far only very little ideas on this thalamic aphasia. So this would be the first step, that we characterize the aphasia language disorder. I think we cannot really name it aphasia. And then the second step would be to then analyze it more precisely from an anatomical point of view. Yeah. So in our study, it was, to be honest, it was a retrospective evaluation. We just checked the patient records, whether our logopedics documented language difficulties, and on this basis we separated the group. So it's just a first look. But it's very interesting for our neurologists, because these thalamic lesions, they cause so many different symptoms, and we are always surprised that, oh, it's a thalamic lesion, and yeah, it's amazing.
I had a question in the beginning of your talk. You referred to the apparent overlap between networks that may underlie syntactic processing production and those that support lexical analysis or sensory motor integration. You didn't name it as such, but you showed the maps. And I was just wondering if you have a hypothesis about the nature of the processing that is supported by these networks to explain what these different language functions have in common. So what is it that these networks really do that makes them support these language functions?
So Dirk, you refer to this slide here, or
I think you showed a Hickok and Powell slide, or
I think this
you mentioned it in passing.
refer to this one here. This one here?
Yeah, and then a little earlier. Yeah, here you go.
Yeah. So, and your question is.
So if at least parts of these same networks underlie functions, language functions, but in very different domains, what is it that these networks really do that allows them to support both lexical integration and also syntactic processing? What's the underlying function, you think?
I think these are different functions. So this is just the level on which you investigate language. So if you go very in detail, then you will find very specific areas and probably very specific fiber tracks. But altogether, it will be a part always of this ventral pathway and a part of this dorsal pathway. And you can call it arcuate fascicle or superior longitudinal fascicle. And the more fine grade you will investigate is, then you will find very specific areas and very specific fiber tracks or parts of tracks. But they have in common this coarse architecture of these long ventral and dorsal association tracks and processing streams. You can extend it even to other domains like motor processing or attention. You will again find this dual pathway model or this dual pathway architecture. So I don't think that they share something. It's just the level on which you investigate it. Then okay. If you investigate it very, very in detail, you will be able to segregate it. Yeah.
Thank you. That's
do you have another opinion?
No, I think that's a very clear, it's a hypothesis, right? But that's a very clear hypothesis, so that there's not actually neuroanatomical overlap. It's just in the overall architecture is what you're saying, but not at the micro architectural level.
Yeah.
The alternative would be that there is something that these networks do that is more that is harder maybe to put into words or more abstract, that allows these neurons and their specific connections to underlie different functions. But either of those are just hypotheses. So it's the only way to find out is to test it at the micro level. So we have another question from Kirana Tsapkini. Are you still up for answering a few more, Dorothee, or is it nighttime?
It was a long day already for me, but I'm looking forward to your questions, of course.
Okay. Another one from Kirana Tsapkini. Is connectivity in the lesion site higher or lower than normal? The diaschisis mechanism assumes that lesion connectivity is compensatory, but could it be a physiological manifestation of the neighboring ischemia?
So it's an interesting question, I guess, but I'm not really. Where is it? Could you help me so that I can?
I skipped over it because Kirana had already.
So is connectivity in the lesion site higher or lower than normal? Is connectivity in the lesion site? The diaschisis mechanism assumes that lesion connectivity is compensatory, but could be in the. It's too difficult for me in this moment. Assumes that lesion connectivity. So I don't get it. Can you help me, Dirk, with this question?
Hi, may I chime in?
Yes,
Just to
definitely.
make it clear if I can. Thank you. It was just a thought that about the diaschisis hypothesis, because I was thinking, is it, if it is higher, maybe it is a compensatory mechanism, just because there is ischemia next to it. So it might be a vascular effect versus a compensatory mechanism itself, because you talk about the diaschisis as a mechanism.
Yeah,
so
but
just
I think we are not able to answer this. So I showing you now the slides where we try to operationalize diaschisis. So the idea was just that if diaschisis is a key mechanism of this early activation increase, then it must happen in areas that are functionally connected to the lesion. Yeah, and this is what we found. This is the only thing what we can say. So we try to operationalize diaschisis by defining these compartments with high and low lesion connectivity. So to make this clear, so the resting state connectivity was taken from healthy subjects, not from the patients themselves. So it just describes the connectivity of each individual lesion. And if diaschisis is an important mechanism, then activation increase should be most pronounced in areas with high connectivity to the lesion, in the sense of a resolution of diaschisis. And this is what we found. But I cannot say you whether it's compensation. I think diaschisis and resolution of diaschisis are not really mechanisms of reorganization. Is it just so early network disruption by the ischemia and the remote dysfunction, which resolves most time very early and is often correlated with this early improvement of function. But I think it's compensatory. It's just reactivation. It's the coming back of the function. Yeah. I'm not sure whether this was.
Thank you.
Dorothee, we do have a few more questions, but I also think we may want to let you off the hook by now, because you've been answering questions for half an hour now. So I think, unless you insist on wanting to answer that, then that's fine. I'm happy to continue, but.
Yeah. So it's on your side. So it's up to you. So if you have additional questions.
I don't. Let's see. Okay then. Okay. Since you are so gracious, Joanna says, I wish to follow up on my question about the right hemisphere shift after left frontal lesions. Can it be explained by the fact that dorsal language pathways are left lateralized, meanwhile the ventral ones are rather bilaterally distributed? And in the same vein, I'll read out another one right away because it's related. So Brenda Rapp says, we found sensitivity to phonemic gradients in the right hemisphere temporal activation in an individual with left temporal lesion. I wonder if the right hemisphere temporal area is specifically recruited for phonemic or subphonemic processing. So those are two hypotheses or proposals to explain your data.
Yeah, so my opinion to this asymmetry of pathways is that there is no macroscopic asymmetry. So this is I think all these studies are methodological, not really convincing, who showed us that maybe these fiber systems are more pronounced in, or this language-related fiber tracks are more pronounced in the left hemisphere. So I don't trust this. It's I think I think it's often methodological weak work. And the other question was, Brenda, we found sensitivity from gradients in the So maybe Brenda, you can comment on this.
Yeah, no, I was just we found activation in the right temporal, superior temporal, posterior superior temporal in very specific tasks looking at subphonemic categorical discrimination kind of things. And so I was wondering if perhaps maybe the right temporal area is just more, I mean, I think it's generally consistent with what you said. It has sort of very narrow functions, and so it might not be broadly recruited for language, but maybe there are sort of very specific things that it might be recruited for.
Yeah, I agree. So I think it's highly dependent on the paradigm. But is it something you observe very often in your tasks?
Oh, this was a single case study, so yeah, I have no idea how common it is. That's right.
Yeah. Okay.
Have you looked at?
It also depends on the language lateralization before the stroke. So I think there are indeed patients who are more bilaterally organized also in the temporal areas. Yeah.
I think that's a good point too. Yeah. Thanks.
Okay, Cindy Thompson has a general question. Why did you not include the right hemisphere as a candidate for recovery in your conclusions?
I didn't. Bilateral frontal. I included bilateral frontal and no right homologue temporal activation.
Okay.
And
so
then
I thought.
Oh yeah. Go ahead.
Can I?
Yes, please.
So I thought in the conclusions that you were attributing the bilateral frontal to domain general networks, but I might have misunderstood.
Yeah. This is another big point because it's difficult to distinguish now what of this frontal activation is domain general and what is language specific. I would say if we have activation in the inferior frontal gyre, something somewhere like here, I would attribute it to language specific activation. You are right, we have this also in the right inferior frontal cortex. But all these more dorsolateral prefrontal areas, the cingulate cortex, the supplementary motor area, I would attribute this to the domain general network. Yeah. So for this reason, you are right. I have to include it. I have to emphasize it more in the conclusions. But therefore, I wrote here bifrontal language regions, but also domain general regions. Yeah. This is right. Yeah.
Yes. And also, too, your data show that you show posterior activation in the right hemisphere for your sentence task. And I'm really glad to see that. So, because we find the same thing in our recovery studies looking at comprehension change, syntactic or sentence comprehension changes, recruit the right posterior brain.
So I think.
So was it a comment or a question?
I think it ties into a follow-up question. I think so, Cindy, by Elena Barbieri, and that will then be the absolute last one I will read out, okay? Because then you need to go to bed, Dorothee.
Yeah.
This is a question by Elena Barbieri. Thanks for the wonderful talk. In 2 studies, we found that agrammatic patients who underwent treatment for sentence production recruited right hemisphere, temporal more than frontal areas. We found that this recruitment was positively correlated with treatment outcomes, and this was found in 2 comprehension tasks, a sentence to picture matching task and a story comprehension task. Do you think that perhaps recruitment of right temporal areas may be a more treatment-induced versus spontaneous recovery mechanism?
Yeah, this is a very good point. And if you can reproduce this, so this would be, I think this would be a great hypothesis. And then it would also be a target region for non-invasive brain stimulation. But I think it always depends on a little bit preserved function in the left temporal cortex. So the question is whether you have preserved functions in the left temporal. So this would be my hypothesis. So yeah, but I think it's a good idea. Yeah, that right temporal cortex might be a target for therapy-induced plasticity, behaviorally and by stimulation. But my hypothesis would be that it depends on some preserved function in the left. Yeah. But this would be an interesting study. So to look this. So how strong your activation depends on in the right temporal cortex depends on preserved rest function in the left temporal cortex. Yeah.
On this note, Dorothee, I think we're really going to let you go.
Yeah, thank you for joining, and thank you for invitation to this lecture. Yeah.
Most welcome. And thanks to the audience for attending. And then we hope to see you again on April 30th for Jamie Riley.